Good morning and welcome to Cardiology Grand Rounds conference from Houston Methodist DeBakey Heart and Vascular Center. Dr. William Zoghbi, Chair of Cardiology here at Houston Methodist, and with me is today Dr. Mohammed Shamsi Pasha, who's a multimodality imager, Associate Director of our Echocardiography Laboratory. And today we are privileged to host Dr. Jonathon Leipsic, who will share with us his insights on recent advancements in cardiac CT for coronary artery disease evaluation. Before we introduce him formally, I would like to welcome our viewers to participate and ask questions for Dr. Leipsic. This can be done in two ways. One is to go to polev.com, enter DeBakey, and second by texting DeBakey to 37607 and typing your message. Dr. Leipsic really does not need any introduction to this audience. He is a worldwide leader and recognized leader in the field of cardiac CT. He's the chairman of the Department of Radiology for Providence Healthcare in Vancouver, and is the vice chairman for research at the University of British Columbia Department of Radiology. He's professor in both radiology and cardiology with the University of British Columbia. Dr. Leipsic is also a Canada Research Chair in Advanced Cardiopulmonary Imaging. This is a distinguished honor in Canada. I know that very well. Dr. Leipsic has over 600 peer-reviewed publications in press or in print and over 300 scientific abstracts. He's the editor of 2 textbooks on the topic. He speaks internationally on a number of cardiopulmonary imaging topics with over 150 invited lectures in the past 4 years. He's also past president of the Society of Cardiovascular CT and was awarded its gold medal in 2019. He was recently named to the prestigious top 1% of most impactful scientific designations by the Web of Science in 2019 and 2020. What a pleasure to have him here today. And Jonathon, it's really a pleasure, a personal pleasure for you to come and join us and waking up early in Vancouver. You will see behind him a beautiful scene of Vancouver, which I've visited several times. And I also share with him, every week, basically being on the editorial board of JACC Imaging and discussing various topics, and his wisdom, his overall view of the field of cardiac CT and its implications are just wonderful. Jonathon, pleasure having you with us.
It's my honor, thank you. I trust that you can hear me well. It's a real privilege to join you watching the video leading in. It made me reflect on all the contributions, obviously, the Methodist and the cardiovascular team has made to the field of cardiology, and also the richness of my friendships and collaborations over the many years with the cardiac CT people, the echo people, and I've had the privilege of visiting your great hospital before, and it's a real honor to share with you an update on coronary CT. I last spoke a number of years ago on structural CT, but I'm going to focus on coronary CT, and without further ado, the slides will advance. I do have disclosures. Most relate to the core lab work that I do, supporting a lot of structural heart disease trials, supporting people like Drs. Kleinman and Reardon, but I take no compensation for that. I have received a grant from GE, and I do give advice to HeartFlow. So, I come to you now 6 weeks following the update of the recent ACC AHA chest pain guidelines, which provide class 1 support for not only cardiac CT, but other tests. But I'm going to try to make a case as to why, for specific patients, I think cardiac CT really should be considered as the first line test, and why the ACC AHA guidelines have elevated it to a class 1 level of evidence A. And I think it's because it helps answer most of the questions we're confronted with when we identify a patient such as this. It's not that stress testing won't continue to play an important role, and it's not that stress testing doesn't answer many other questions that CT doesn't. But as it relates to such a patient with symptoms of possible coronary disease, cardiovascular risk factors, male patient, mildly obese, I would posit to you that the question that we really want to have answered non-invasively is not what is the microvascular function. It is not, is there regional wall motion abnormality at peak stress? I really think first and foremost, we want to know if the patient does or doesn't have coronary disease. We've learned for many, many years now from people like Dr. Nasir, from Methodist, of the power of zero, the power of excluding atherosclerosis, be it with a calcium score or a CTA. And I think that power of zero has really enabled us to understand the clinical value of medical therapy and questioning it in the absence of atherosclerosis. So if you agree with me, which you may not, that in this case, we want to know if the patient does or doesn't have coronary disease, I would posit to you that the traditional or historic ACC/AHA guidance around the workup and management of such patients is fundamentally limited. And I think it's for that very reason that the updated guidelines published again October 26, I think it was, very much leaned into a CT first strategy. As you could see, the historical pathway really was, it started with clinical adjudication of symptoms, which I didn't appreciate as a trainee, but when you reflect on the Netter pictorial imaging representation or image representation of angina, you can appreciate how ethnically and sex and gender biased it is, right? The whole concept that if you don't manifest your symptoms exactly like an older white male coming out in a snowstorm in Boston, then your symptoms are atypical. I think those days are fortunately increasingly in the rear review mirror. You know, if you're a woman with symptoms that are different, I don't think we should be calling it atypical. And I think that bias, whether it was conscious or unconscious, led to, as we know, treatment decision-making that was perhaps not supported by clinical presentation, but rather, again, bias. And then the non-invasive stress tests. And again, I think non-invasive stress tests will continue to play a very important role. You know, does the patient have pulmonary hypertension at peak exercise? Is there a viability in someone with known disease? Is there valvular function? Valvular dysfunction. All of these things are very important. Is there microvascular dysfunction? But I think these questions are relevant in a different population, and perhaps after answering the question whether or not the patient does or doesn't have coronary disease. We know this pathway is limited. I'm not going to spend a lot of time on that. And we know that both from the NCDR database, from Pam Douglas and Manesh Patel, that many, many patients that go to the cath lab after a stress test are not found to have actionable coronary disease. And we also know, albeit older data from Dan Berman, amongst 101 patients with ICA adjudicated left main disease that had undergone SPECT previously, that many of those patients, about 44% of those patients, had either normal or mildly abnormal SPECT tests, highlighting that, again, these tests are valuable, but they don't really answer the question as to whether or not there's an anatomical stenosis, and certainly provide you no information as to the presence or absence of atherosclerosis. So if you'll agree with me that the first question that we want to have answered is there plaque? You know, is there atherosclerosis? Is there a stenosis? I think CT, obviously, as an anatomical test, is the best test to answer that question. These are historic data. These are 13 years old already from 64 slice CT, highlighting that no test has a higher negative predictive value than CT. And CT, even 13, 14 years ago, had a fairly high positive predictive value. When we looked more recently at the ischemia trial, we served as the core lab along with Matt Budoff and Jim Min. And as you know, we were doing CTs in a blinded fashion to exclude left main disease and confirm the presence of anatomical stenosis. And what we found when we compared those data to the QCA analysis done by Sripal Bangalore at NYU is that the agreement between CT and cath was 97.1%. So not perfect agreement. CT absolutely does not have the temporal resolution of cath. It doesn't have the spatial resolution of cath. But clearly, there's no better non-invasive tool for the identification of and the exclusion from anatomical stenoses in the coronary arteries, even in what is considered to be a fairly high-risk population, patients with a high burden of calcium and complex coronary disease. The second reason I think that the ACC/AHA leaned in and provided class 1 support for CTA is because it's a powerful prognostic tool. Much of that prognostic data I know has been developed over the years, again, in collaboration with many people at Methodist. including Dr. Al-Mala from the Confirm Registry. But what we could see here is just two slides highlighting not only the prognostic utility of CT, but the incremental prognostic utility. This is from PROMISE, 10,000 Americans randomized between CT on the left and functional testing on the right. X-axis is time, Y-axis is the percentage of patients with events. What you can see here is that a negative SPECT is associated with a fairly low event rate, but 2.5 times higher than a negative CT. Because of course, we know that a negative SPECT does not rule out plaque or atherosclerosis. And importantly, a negative CT has had a significantly lower event rate. This has been consistent in many, many registries as well. And I think importantly, what we don't show here, or what is not shown here on this slide from Udo Hoffman, is that the length of the warranty of a negative CT is longer than a negative SPECT. In many registries, it extends up to 7, 8, perhaps even 10 years. So the negative likelihood ratio, the power of zero as coined by Quorum as it relates to calcium scoring, is very much an opportunity with CT to not only exclude anatomical stenosis, but risk stratify the patient with a very high negative likelihood ratio. In addition, if we look at the second lowest Kaplan-Meier curve, here you can see patients with plaque but no stenosis. You compare that to patients with a mildly abnormal SPECT. And what do you see? A mildly abnormal SPECT is not associated with any incremental hazard as compared to a negative SPECT. So if you have two patients waiting for you for treatment, and one has a mildly abnormal SPECT, one has a normal SPECT, and they come to you and say, Dr. Leipsic, do I have coronary disease? You answer with, I'm not sure, but your risk is not that high. And then you tell them they should take medical therapy, and they ask you why. And you say, well, because based on population-based risk factors, you have a 7.5% 10-year event rate. And they look at you and say, what population are you looking at? I'm from Thailand originally. And then you tell them, well, it's largely Caucasian population from the US. This is not a very powerful conversation, as you know. On the other hand, what you could see here is that if you have mildly abnormal CT, your relative risk is threefold higher. This is almost exactly the same relative risk as what we found in the Confirm Registry. And people questioned it as ascertainment bias, but it was seen the same, almost the exact same threshold in PROMISE. Patient with plaque comes to you and says, am I at increased risk? You can tell them, yes, you are. Not based on population-based risk factors, but based on the fact that those patients have atherosclerosis. And that informs a much richer conversation, in my opinion, with said patient. In addition, if we look at more recent data from the ischemia trial published by Harmony Reynolds about 8 weeks ago in Circulation, you can see that the extent and severity of anatomical findings by CT was associated with a dose-response relationship with mortality. On the other hand, the extent and severity of stress testing findings exhibited no relationship with incident mortality, highlighting that not only is CT powerfully prognostic, but the prognostic utility, at least in ischemia, at least in PROMISE, extends well beyond that of traditional stress testing. Now, I won't spend a lot of time talking about it, especially since it's not playing, but CT, of course, provides us information beyond the presence or absence of stenosis. It actually allows us to not only identify stenosis, but provide at least a qualitative assessment of the plaque morphology. Is it calcified? Is it non-calcified? Is there positive remodeling? Is there low-density plaque? As well as provide an assessment of the totality of plaque, understanding that the drivers of risk is fundamentally related to the totality of plaque, the overall plaque volume, as well as the prematurity of plaque. And then beyond that, incremental value of identifying plaque morphology. We don't have robust tools as of yet to allow us to quantify plaque and track response in the clinic, but I don't think those are far off, and providing an interesting opportunity for us to explore mechanisms of risk as well as treatment response. To that end, we know that, as mentioned, plaque burden is probably the primary driver. As we've seen, patients with more plaque are more likely to have events, but we continue to explore plaque morphology. These are old data, 12-year-old data from Jaganarula and Sadako Murayama, highlighting that the very features seen on IVUS that have connoted an increased risk of incident myocardial infarction appear to provide incremental risk prediction among CT, positive remodeling, and low-density plaque. We've also seen other people explore, mechanistically drivers of culprit lesions, including mechanical forces. This is very thoughtful work that's actually now out in Press and JAMA Cardiology from the ICONIC registry, which we participated in. But this work is from Dong-Hee Han, who's working with Dan Berman at Cedars. And he did a very thoughtful analysis looking at culprit lesions within the ICONIC registry and identified that the predictors of culprit lesions included, the ability to discriminate that using diameter stenosis, adverse plaque characteristics, but incremental to that were geometric lesion characteristics, such as the distance from the ostium, the location of the bifurcation, and tortuosity. Finally, before we pivot on to understanding how guiding treatment with CT can improve outcomes, I think part of that insight comes from our understanding that plaque progression is a needed step prior to MI. When I was trained, I was, of course, always reminded of these important works, starting with John Ambrose's work in 1987, that patients who experienced myocardial infarction often didn't have a high-grade stenosis on preceding invasive angiography. Importantly, and what wasn't reflected onto me with those studies is that oftentimes the invasive angiogram was anywhere from 10 to 40 months before the myocardial infarction. And yet what we've learned over the years in patients with either unstable angina or people who are imaged more temporally close to the myocardial infarction or imaged at the time of infarction or at autopsy, that the lesions that were causing myocardial infarction were much bulkier than were evident 10 months, 12 months, 40 months before the myocardial infarction. This slide put together by Amir Ahmadi, who worked with us previously at UBC, who's with Jagat Narula now in New York, really highlights this important insight that when we look at a patient from a CT perspective and we identify non-obstructive plaque, the message there from this slide is not that non-obstructive plaque is more sinister than severe critical stenoses, but rather that ignoring non-obstructive plaque leaves the patient exposed to risk of plaque progression and incident myocardial infarction. We've shown that with others in registries such as Paradigm, highlighting that plaque progression was a key determinant of the development of culprit lesions and incident myocardial infarction. So I think the future of cardiac CT will not only be to identify the presence or absence of stenosis, and then of course the overall qualitative assessment of plaque, but potentially to allow us to actually quantify plaque and track plaque progression or stabilization. I think we need tools to do this, and I know there are a number of people that are looking at that will be AI supported, that will allow us to actually integrate this into our practice. Not there yet, but I think 2022 will see the integration of more of these tools in time. Finally, before we pivot to physiology, I would highlight that I think the ACC really leaned in with a CT-first strategy, because what we've seen consistently in registries and randomized trials is that CT-guided medical management improves outcomes. We saw that initially from the CONFIRM registry, an observational study, 30,000 patients followed in time from many, many sites across the globe, including, again, with Dr. Al-Mallah, from Saudi Arabia and Henry Ford. And what we see here is that patients who are treated in the presence of plaque with statin therapy experienced a significant reduction in incident major adverse cardiovascular events. On the other hand, patients who are treated in the absence of atherosclerosis derived no benefit from statin therapy. This was criticized, this work, because there was observational and there was concerns about downstream treatment decision-making that was not included in the CONFIRM registry. But it was our first insight, along with some of the very great work from MESA and beyond around calcium scoring, that treating patients with disease drives improvements in outcomes. Treating patients without disease is often ineffective. And building on that, what we saw from the West Danish Heart Registry, very important data and very contemporary data, you could see here that patients who are treated on the basis of CTA as compared to those treated on the basis of functional testing, which in Denmark was largely PET, so contemporary modern functional testing. You could see here that patients treated based on the results of CT had a 30% lower myocardial infarction rate. Similarly, in Scott Hart, a randomized trial looking at traditional care versus traditional care and CT, you could see from the 5-year outcome data published in the New England Journal that patients treated on the basis of CT had a 40% lower cardiovascular death and MI rate. Now, people may reflect on this and wonder, how is it that CT reduces myocardial infarction? And even though I'm zealous about CT, I recognize when I do a CT, the radiation doesn't stabilize plaque. But I think the key, of course, is that it informs and provides rich information to the nurse practitioner, to the general practitioner, to the cardiologist about the patient-specific anatomical disease burden, whether she or he actually has atherosclerosis, how extensive is it, and is it premature? Versus traditional care, which often leaves titration of medical therapy based on traditional cardiovascular risk factors. I think therein lies the opportunity to personalize treatment and target those who are likely to derive benefit from revascularization. What we've also seen in the randomized trials, as well as in the observational registries, is that personalized therapy, titrating medical therapy based on the presence or absence of disease, and really working with the patient allows for shared decision-making in a fashion that empowers the patient and enables the patient to understand why she is being treated with medical therapy potentially for 30 or 40 years, and really results in a greater adherence to medical therapy than traditional care. And I think therein lies a real opportunity to personalize care and optimize downstream clinical outcomes. So it's for all of these reasons, and I think some others, that about 2.5 years ago, the European Society of Cardiology gave a Class 1 indication for CTA. And it's for those reasons, again, that we saw the ACC-AHA guidelines updated in October of this year, highlighting that CT really should be considered as a Class 1 indication, level of evidence A, only test to be given that designation, because it's powerful in diagnosing disease, in risk stratifying, and for guiding treatment decision-making, a unique distinction in the guidelines at least, and you could argue whether appropriate, but in the guidelines as compared to traditional stress testing. To highlight that, you can see that if you look at the pathways that are offered, if you initiate with stress testing, regardless of the results, at least in the guidelines, regardless of the results of the stress testing findings, it ends with guideline-directed medical therapy. Whether you have a mildly abnormal, moderately abnormal, or severely abnormal stress test, those patients end on guideline-directed medical therapy. And that is because I think we've seen, while powerful prognostic tools, functional testing in the absence of understanding anatomical disease burden does not inform catheterization in a powerful way. It just doesn't. And I think it's for those reasons that the pathway to the cath lab, if needed, goes through anatomical disease and then either FFRCT, which we'll talk about, or functional testing, following the identification of an anatomical stenosis. The other challenge I have with this pathway, though, is as serving as the CT core lab for the ischemia trial, I'm not confident how you can have a patient with a severely abnormal stress test and not exclude left main disease prior to just leaving them on guideline-directed medical therapy. We identified about 6% of patients with core lab adjudicated moderate to severely abnormal stress tests with left main disease with good concordance with cath. And so I think that this pathway of just leaving these patients on GDMT without knowing if they have left main disease is, I'm not sure I would feel comfortable with that personally. Finally, I wanted to pivot onto this concept of physiology, because I think physiology is important in providing guidance around management of lesion-specific physiology. And we know it's, in fact, lesion-specific physiology that is important in guiding decisions around revascularization. We've seen that in multiple randomized trials, but also from large registry data. This is from Ontario, from the group from Sunnybrook. What you can see here is that patients with abnormal physiology derive benefit from revascularization, and patients with physiology defined by an FFR above 0.8 derive harm from revascularization. Therein lies the opportunity, I think, of physiology as well, is to actually not just identify a vessel that is quote unquote ischemic or may have abnormal flow, but really identify a lesion, and then characterize the phenotype of physiology to understand whether the patient will derive benefit from revascularization or not. About 11 years ago, I was introduced to this concept of FFRCT. I know you use it clinically at Methodist, so I won't spend a lot of time around the background. But what we know is that it's feasible on the basis of anatomical data extraction using artificial intelligence and machine learning, and then through the application of computational fluid dynamics to solve for the equations of pressure and resistance and flow across the coronary tree. The test is not perfect by any means, but what we've seen is that it has the highest diagnostic performance compared to invasive FFR, with an accuracy of about 86 to 88%. But importantly, as was shown here in the Pacific trial, I think the real opportunity is not to compare to PET. I think PET has tremendous richness of information. I've learned a lot from your center, from Methodist, and the tremendous PET work that has been published consistently over time. So just recent work that was published as well by Dr. Almala and Jack Imaging. So I think PET is providing you rich information around CFR and other important prognostic findings. I think the power of CT and then selective use of FFRCT is a very specific question that is being answered. When you find an anatomical target, the question is not, is there a flow abnormality in the LAD? I think the real question is that lesion causing significant resistance of flow, and is there significant translesional gradient that will be improved by PCI? And I think that is uniquely answered by this combination of anatomy and then the calculation of lesion-specific physiology. Now, many will say, well, why don't you just send the patient to SPECT after a moderate CT? And I think that's a reasonable thing to consider. I think one of the challenges we found is from the work from Ibrahim Danad and Paul Knappen from the Pacific trial is that if you do that, you don't really incrementally improve your accuracy of the detection of abnormal FFR, but rather you trade the sensitivity of CT for the specificity of SPECT, but the overall accuracy is not improved. So I'm not sure that SPECT after CT or hybrid testing particularly enriches the ability to discriminate FFR. Now, how has this tool impacted clinical decision-making? I think what we've seen from the advanced registry, over 5,000 patients, is that first and foremost, it enriches cath lab referral. It helps identify, I think, patients that have historically been missed by non-invasive stress tests that are, again, powerful in answering other questions, but are not very effective at identifying lesion-specific abnormal physiology. In addition, it helps avoid catheterization in patients who are not found to have actionable coronary disease. The PCI to ICA ratio across the advanced registry and many other studies would suggest that when you send a patient to the cath lab with a CT and an FFRCT, the revasc rate hovers around 75 to 82%. This compares to CT alone, typically around 60, and lower yet with isolated non-invasive stress testing. The other opportunity, though, I think of integrating physiology is to better identify patients who can safely be deferred from invasive angiography. What we saw in the ischemia trial is about 35% of patients crossed over. What we see in the advanced registry is by excluding physiology, abnormal physiology, the revasc rate was roughly 6% in those with negative FFRCT, suggesting that the patients are getting adequate symptom relief with medicine alone, and importantly, are exposed to a very low incident MI rate. Among 1,600 patients followed out to a year, the MI rate amongst those with a negative FFRCT there were only 3 MIs. So I think it allows for the risk stratification of patients beyond the anatomy and allows to identify which patients will likely derive benefit from revasc and which patients can be safely deferred from revasc. This has been recently built upon in a meta-analysis published by Bjarne Nørgaard and Hart. And this is a bit of an eye chart, but I think what it really highlights, again, over 6,000 patients followed for just over 2 years, median follow-up, is that FFRCT, similar to invasive FFR, allows for the discrimination of risk beyond anatomy. That the lower the FFRCT, the higher the risk, the greater the benefit of revasc. In the setting of a negative FFRCT, the event rate is very low despite anatomical coronary disease. Building on that, I just wanted to highlight some important work from down the road from Niels Johnson, who's a fellow Canadian, who's at, as you know, Memorial Hermann, highlighting that from very large registries of FFR, that patients with lower FFR are at a higher risk of incident event, and that event rate is mitigated by revascularization. So in the randomized trials, we know that patients had to be randomized across a binary cut point, but in clinical practice, the lower the FFR, the higher the risk. We've seen similar data published by Abdul Dahid from the 5-year NXT data, but here is data, actually 10-year data from FFRCT presented by Quan Ku at EuroPCR from the Discover Flow study. Importantly, this is a small cohort. It's a very small cohort compared to the data published by Niels. But what you could see here is we're seeing very similar signals. And I think that's an important learning as we integrate it into our practice, is that FFRCT is not a binary tool, but if you identify someone with severely abnormal physiology co-localized to a lesion, those patients are very unlikely to get adequate symptom relief from medicine alone and are exposed to a higher rate of incident myocardial infarction and derive benefit from PCI. So I think these are continued learnings. We need to continue to learn about the technology and how to use it in our practice. But those are some key points from my practice that I wanted to share. Now, as far as what range of stenosis should be considered with, the CAD-RADS document is continuing to be considered. It's not yet out, but what we saw in the ACC-AHA guidelines, and very similarly, I think will probably follow in CAD-RADS, is that we should consider it in any vessel we're considering for revascularization. So in a symptomatic patient, in a CAD-RADS 3 to 4A, so a 50 to 90% stenosis, or perhaps in the higher range of CAD-RADS 2 when proximal. So obviously not a CAD-RADS 2 and an OM2 lesion, but in the proximal LAD, owing to the inconsistent relationship between anatomy and physiology, and to better identify which patients should be treated medically and which patients should be considered for revascularization. Sorry. I will share with you that everything I've presented to you is observational. There was a randomized trial looking at cost in the UK, which showed that FFRCT could reduce unnecessary cath and improve the PCI to ICA ratio, but without a significant reduction in cost. That trial was called Forecast, but with equivalent costs to traditional CT care. But this trial that I share with you in the design of Precise, this was led by Pam Douglas. It's done enrolling as of April of this year. And we look forward to seeing these results presented, I hope, next year at the ESC, hopefully in person, so we can all meet together in Barcelona. I wanted to close with a few areas of continued investigation around FFRCT. The first is around the ER patient population. You know, we have data now, median follow-up 7.5 years. It's coming out. It's IMPRESS, looking at outcomes of our patients who underwent cardiac CT. And what we found was, of course, that if you had very mild coronary disease on cardiac CT, in a small cohort, it was about 900 patients that have median follow-up of about 8 years, the outcomes are fantastic. I think one of the challenges we've always had is once we identify anatomical disease, particularly in the setting of high sensitivity troponin, you know, what do we do with these patients? We've learned from Kavita Chennaiyan and her team from the Beaumont that there may be a role for FFRCT, and we've explored it locally in, again, those CAD-RADS 3 and 4 lesions to better refine which patients should come in, which patients should be sent home. And she actually presented longer-term follow-up data at AHA, and I believe those data are in press. We've also explored patients with peripheral vascular disease. I'm sure none of you would be surprised if I told you that many patients with peripheral vascular disease have significant burden of coronary disease, high burden of anatomical disease, and abnormal physiology. I'm sure this wouldn't surprise you. But, you know, I was always taught, and as is practice in our site, patients are just really, they go through their procedure. If they have a pharmacological stress test that's not meaningfully abnormal, they don't get revascularized. They don't have their coronary disease explored. But the same group in Europe recently published a small study, about 230 patients, and they compared a CTA and FFRCT guided revascularization strategy, selective revascularization versus traditional care. and found at 2 years a significant mortality reduction amongst those patients who were selectively revascularized on the basis of anatomy and physiology. This I was very surprised by. And obviously it's a small study, it's not changing guidelines, but it makes sense that we should explore this in perhaps a larger randomized trial, that these very high-risk patients are perhaps being undertreated because a lot of our understanding is from the turn of the millennium, and perhaps it's time we reflect on these patients and better understand if we can improve outcomes. I also wanted to highlight a concept of coronary volume to mass. This is a very interesting concept that I think many people at your institution will continue to explore and teach us all about, because it's a concept of vascular health. The idea that if you have small coronaries and your myocardial demand is low, you have a modest myocardial mass, your resting flow may be reasonable and you may accommodate plaque and hyperemia and not have abnormal physiology or angina. But if you have small coronaries relative to a higher myocardial demand, your ability to accommodate a stenosis is going to be very modest because your resting flow conditions are tenuous, right? You're barely meeting the demand. And so we've explored this in many patient populations. This is from the advanced registry, looking at what the distribution of this VM is. And what we found is that there's a significant heterogeneity. This perhaps a master's athlete who's trained her heart to accommodate hyperemia and exercise. And as such, such a flow situation, we can often be surprised at the atherosclerotic burden that can be present in the absence of abnormal physiology. On the other hand, you can have a sedentary patient with very small coronaries relative to myocardial demand, and you could have a very modest stenosis, and this patient can dissipate pressure in a very meaningful way with a very modest stenosis and have angina. And yet people can often dismiss those symptoms because the focality of the lesion is modest. What we've seen is that patients with modest stenoses that have abnormal physiology almost very much commonly cluster in this low VM range. And so I think this coronary volume to mass is an important opportunity for us to explore why some patients develop angina, why some patients have abnormal physiology, and better understand this concept of vascular health that may be extracted from a resting CT. Obviously, I think this is just beginning. I think that a number of companies will work on flow models around resting flow, around understanding myocardial flow, and correlating with things such as PET. Obviously, that work is just beginning, but we've seen some of those data already published, trying to understand the myocardium subtended by any anatomical stenosis, but also resting flow beyond coronary volume to mass. So finally, I wanted to close where I think the future will really go is that I think finally we have a test, as CT is being used more and more often in evaluation of patients with symptoms, that will hopefully be explored by our interventional colleagues to actually plan their coronary interventions. And I say that because I know that the great structural heart physicians at your institution would not go do a TAVR without an evaluation of the annulus. That would just not be considered modern practice. And yet still, I'm sure at your site and certainly at mine, many patients still get to the cath lab without even knowing whether the patients have coronary disease. No other invasive procedure in medicine that I know of is there not a significant anatomical understanding of what is going to be targeted, right? We don't go do endovascular aortic aneurysm repairs without even knowing that they have an aneurysm. And we don't do it without a plan of how that aneurysm is going to be repaired endovascularly. And yet coronary disease is managed often in this fashion, leading to many patients going to the lab without coronary plaque, and many patients going to the lab with very sinister atherosclerosis. And our poor interventional colleagues have to make ad hoc decisions around revascularization. We know this pathway is limited and challenged. We've seen repeatedly that this algorithm leads to many patients being incompletely revascularized. 40 to 60% of patients incompletely revascularized in the ischemia trial as presented by Greg Stone at the ACC. And we know that incomplete revascularization leads to higher rates of incident myocardial infarction, 35% higher than those that are completely revascularized. So how can CT help? I think it can start by providing fluoroscopic angles that can help optimize the projection of any individual lesion and the cannulation of the left main, understanding the left main bifurcation. This is thoughtful work from Nico Piazza from McGill, as well as a group from Krakow. Again, it may not be needed in all cases, but it's free information that's already there, acquired as part of the CT. We can profile coronary lesions and provide fluoroscopic angulation to help optimize the visualization of said lesions. And the opportunity there is, here is an example. This is an angle that would be typically used in a cath lab. And yet when the interventionalist took this patient to the cath lab and she used an angle provided by CT, she appreciated that the lesion was in fact a centimeter longer than what would have been predicted using her traditional working angle. How about lesion preparation? We know that rotablation and lithotripsy are increasingly used, and we know that CT can definitely identify calcium. And so being ready that you're likely going to be confronted with a heavily calcified lesion, having the tools ready to manage said lesion, I think is an important opportunity. And again, free as part of the diagnostic workup of this patient. You can evaluate the coronary disease and the lesion morphology. Of course, I don't know why this isn't playing, but this shows a critical left main lesion. And I don't think that we should be diagnosing critical left main disease, at least without augmenting the likelihood of identifying such a lesion with CT, creating an opportunity for shared discussion in advance of the cath, and for the interventionalist to go to the cath lab with a greater understanding of the likelihood of left main stenosis. Finally, how about physiology? I think what we've seen, and this is from Carlos Colette and Patrick Sarois, is that when CT enriches cath lab referral to some extent, but when you have complex disease, the CT anatomical syntax score is exaggerated as compared to the invasive anatomical score. On the other hand, the functional syntax score, when they integrated functional evaluation with FFRCT, you can appreciate that the non-invasive functional syntax score agreed very well with the invasive gold standard, creating an opportunity to provide a functional roadmap to the proceduralist such that she can take a patient to the cath lab, understanding not only the anatomy, but the impact of the anatomy on physiology. Here's such a case, critical LAD lesion. You don't need physiology, it's greater than 90%, but there was a moderate to severe right coronary lesion. Instead of telling the interventionist, go figure out what to do with the right, we can augment the referral by saying the LAD is severely abnormal, the right coronary artery has normal physiology, and will likely not need to undergo invasive physiology or revascularization. How about the phenotype of physiology? And I think this lies an opportunity as we go forward, and this is where I'll close, last couple of slides, is that when we interrogate physiology, we don't want to just know if the physiology is normal, abnormal in the LAD. We know from the invasive world, looking at mechanized pullbacks in this case, or IFR pullbacks, that the pattern of physiology can very much determine the likelihood of improvement of physiology with PCI. Here you can see all three of these patients have abnormal physiology below 0.8 in their distal LADs, but the path there is very different. This patient has a very focal translesional drop in their pressure. This is amenable to PCI. This is a patient who has significant resistance to flow of a focal lesion. These focality of lesions probably drives an increased risk of MI, as shown in some studies, but also driver of angina. That is likely going to be improved by PCI, because once you relieve that focal pressure loss, this likelihood of a significant improvement in pressure will ensue. On the other hand, these diffuse patterns are much more challenging to treat percutaneously. And I think identifying those patterns beyond the absolute value of the FFR will be important. This is something that's being explored by the group from Ulst again, and something that we do, that not only do we report the value of the physiology, but how do you get there to better refine which patients should be considered for referral for invasive angiography. And finally, in the future, I think there will be an opportunity to explore this concept of an interactive planner to actually idealize the lumen and recalculate pressure to better understand the likelihood of recovery of physiology following PCI. This concept of an interactive planner has recently been validated by the group from Ulst again in a study called P3. P3 essentially compared the post-PCI FFR to the predicted post-PCI virtual FFRCT. In this case, you could see pre-PCI FFR of 0.81, post-PCI FFR of 0.90. Here it is idealized virtual stenting of the right coronary lesion and the recalculation of pressure with good agreement in this case. When they analyzed this across a large number of cases, the agreement was not perfect by any means. There was a mean difference of 0.02 with some scatter. But this is the first exploration of this tool to try to understand, particularly in serial lesions and in complex atherosclerosis, whether or not PCI will meaningfully improve physiology. As we know, PCI, in the absence of meaningful improvement in physiology, is not associated with the same positive outcomes as PCI that actually improves physiology. The last case, severe lesion in the circumflex, abnormal physiology, both calculated and measured. Virtual calculated post-PCI FFRCT and measured post-PCI FFR, significant improvement in both cases. In this case, good correlation between the tool and the actual measured FFR. So I will close there. There's obviously much more we could talk about. There remain many, many challenges. Obviously, we need more data, particularly as it relates to the final tools, understanding how to use them cost effectively. We need randomized data. But I think what we'll see over time is that CT and other non-invasive tools, as we've seen in the field of MR and echo and beyond, is that we're going to use more and more algorithms to extract more and more information from the CT to better serve our patients, to better understand their risk, and to help triage treatment decision-making. Thank you again for this honor.
Thank you very much, Jonathon, for really an amazing state-of-the-art talk on CT and where we are in the diagnosis, prognosis, and management of coronary disease. I think we ask the audience to send us some of their questions. I will go ahead and start, and we'll ask Dr. Shamsi Pasha also to ask some of his questions. Maybe two questions for you. One, you mentioned something that prognosis-wise, if you have ischemia on a physiologic test versus a CT, that the CT prognosis, although you may have ischemia on a nuclear or otherwise test, it has a better prognostic information. Is it because of conceivably the differences in load of the disease and the other vessels? How do you put this together?
I think that's a really important question. I think what we've learned over time, and we've seen a number of such studies, actually some elegant work from the group from Manzino, the group from Yonsei University in Seoul, Hyuk-jae Chang's group, that fundamentally, as we know, the driver of risk really is atherosclerosis as it relates to the overwhelming majority of patients in this basket, right? If we're talking about CAD-related complications. And I think that what we've seen over time is that stress testing provides you information beyond anatomical coronary disease, no doubt. But it also has higher rates of discordance with the presence or absence of atherosclerosis. And so I think that what we found is that independent of the stress testing findings, that it's really the anatomical disease burden, not necessarily the stenosis burden alone, but the extent of atherosclerosis that is a driver of myocardial infarction. And I think what we saw, for example, in the ischemia trial, is that amongst patients with core lab adjudicated moderate to severely abnormal stress tests, 20% of those patients didn't have a stenosis greater than 50%. And I think that's a limitation, right? I think that a lot of stress testing tools provide us rich information around coronary flow reserve and myocardial blood flow. But I think that there is a fundamental disconnect between the extent and severity of anatomical disease, which it seems is a primary driver of events. And I think that's probably why we're seeing that disconnect.
Dr. Pasha?
Well, thank you so much, Dr. Leipsic, for sharing with us a very insightful presentation. My question to you, and I'm not trying to create a turf war between physiological assessment of CAD and anatomical, because there is always will be kind of debates on both sides, but the endorsement of CT FFR in the guidelines, and as you mentioned, it really has to be in appropriately selected patients because there will be some lesions that will not be accessible. My question to you, at your experience and at your institution, for moderate lesions between 40 to 70%, and you have an intermediate CT FFR between 0.75 to 0.85, what has been the approach to these lesions? Would it be referring them for an additional functional test, or basically would there be a need for more invasive assessment for these lesions in patients who have symptoms of chest pain?
This is a really great question. Our approach would be to treat those patients medically. I think the evidence right now is very clear from the invasive world that the relative risk and the risk of events very much relates to the depth of the physiological disturbance. And the event rate in the gray zone in FAME2, for example, or in large physiology registries is low. And we know that FFRCT, if anything, has a somewhat downward bias because of the aggressive hyperemic model. So patients that are in the gray zone, we treat medically unless they have unless it's multivessel gray zone disease or perhaps a high translesional pressure loss in a proximal location. So, for example, if the value is in the very prox LAD and it's 0.94 to 0.76 over in the very proximal lesion, with a very severe translesional pressure loss, we will be more aggressive in those cases, and we publish that the delta FFRCT is incremental to the absolute value. But largely, in a moderate 40 to 90% lesion, in the absence of abnormal physiology below 0.76, single vessel disease, we'll treat medically. We don't say that the patient will never see you again, obviously, or that it's impossible for you to get to the cath lab. But we don't layer testing after that. We're not blessed like you are to have such elegant. We don't have access to cardiac PET, so that is definitely a limitation. But I think what we've seen from the registry data as well as our own data is that those patients do very well, independent of their anatomical disease, and they typically get good symptom relief with medicine alone. So we stop it there.
Jonathon, a question from Dr. Mamarian. He said, an excellent talk. Agree that identification of atherosclerotic plaque by CTA is a critical element in identifying risk and making treatment decisions. You discussed the value of calcium scoring. Since hybrid imaging is becoming the gold standard, why not add a CAC score to a SPECT or PET study to assess both anatomy and physiology in the same setting?
It's a good question, and I think that first of all, it's not surprisingly a good question. Dr. Mamarian has taught me a great deal about management of coronary disease. So, but I would ask John that ultimately, I think the fundamental issue would be, depending on the risk of the patient, that I think that exclusion of coronary calcium is important, and I think the burden of calcium in an untreated patient population, not on statin. A statin-treated patient population, I think that the value of the calcium score is obviously going to be less. But also the inability to exclude left main disease or significant anatomical coronary disease, I think remains a limitation. And I think that what we've seen repeatedly is that SPECT is relatively insensitive for left main disease and for triple vessel disease owing to balanced ischemia. So I think one of the messages from the ischemia trial is that anatomical awareness of the presence or absence of left main disease and triple vessel disease remains important. And of course, you don't get that with a calcium score, no matter how good you are at looking at it.
Jonathon, another thing you alluded to towards the end of your talk, which is a bit controversial, I would say. But
okay.
I would you showed a slide where you had stress ECG, you had a nuclear, you had other, and it said do a CT before an intervention, right? And the question is, I would say most people, if you have significant ischemia and you wanted to treat more invasively, they probably would not go to the route of doing a CT to assess the anatomy to help the interventional cardiologist, etc. Why would you take such a stance?
Yes, I'm glad you asked me to clarify that, because no, I wouldn't. I wouldn't do that. Wasn't what I was meaning. What I was meaning is that if let's say at Methodist, and again, I think to the questions, I don't expect that 100% of patients are going to move from stress testing to CT, but say that moves from 5%, 10%. I know Methodist has very much been leading in cardiac CT for many, many years, so I think you have a much higher rate than most centers. But say it gets to whatever it is, whatever threshold that will be, once the CT is done, what I'm saying is that should be explored, by the interventionalist, in collaboration with the interventionalist. So if CT was the first line test that is leading to a referral to the cath lab, I think it creates an opportunity, just the way we've seen in structural disease, for the interventionalist to glean from that rich information that can help inform their decision making. So it's not so much if the stress testing was the referral pathway to the cath lab, then proceed and do as you've always done. But I think it is a unique opportunity because of the fundamental capacity to interrogate anatomy and plaque morphology and location and so on, that once a CT is done, we need to engage with our interventionalists so that they can do as they've done in the structural space and really work with us to learn how they can use this anatomical data in a way that, regardless, you continue to do SPECT or whatever the pathway is, the interventionalist is not going to say, show me the SPECT so I can size my stent, right? I think this is a unique opportunity of anatomical imaging. We have to show that it improves outcomes. We don't have that data, but I think what we've seen in the structural space is that it can enrich sizing and decision-making and fluoroscopic angles. So not ordering CT after the stress test, but once it's done, consider using it and exploring it for treatment decision-making.
Yes, I'm going to ask our staff to update our POLEV, but I will ask you one more question before we see any other questions. What do you do with patients who had previous stenting who came with chest discomfort? With CT, what's the status there? Because obviously many of our clinicians are listening. Should we go for a physiologic test or an anatomic test with CT?
Yeah, I think what we've seen is that the guidelines now provide a class 2A for patients with known disease for CT. I think that this is where multimodality imaging is so important. It really depends on what the question is being asked. If the patient had known disease and there was left disease in the right coronary, there was disease remaining in the right, the LAD was stented, and you really want to know, is there progressive stenosis in the right coronary? I think CT is reasonable. But when you have an incredible PET center as you have, or also tremendous stress echo and SPECT, I think patients with known disease and prior revas generally should go for stress testing. Not that CT plays no role, yes, but the balance would shift definitely towards the stress testing side.
Very good. Well, we want to thank you for an amazing Grand Rounds, Jonathon. Really a pleasure to connect and for you to share your thoughts regarding the current status of CT and coronary disease, and wish you luck and hopefully to see you again in person sometime at Houston Methodist and among us.
Thank you so much. It was a real honor. I wish you all nothing but good health, and hopefully 2022 will have more shared collaborations and in-person meetings. Thank you for this opportunity.
Happy holidays to all. Thank you.